Alrighty, so we're going to go ahead and get started since we've got a lot to cover and we're going to promptly need to end at 12. So I'm Erica, I'm the Diabetes Education Coordinator here at Bonheur. And today we are going to have 3 presenters to present our school care plan update for the upcoming school year. And those presenters are going to alternate. It's going to be one of our clinical diabetes educators, Madison Greer, as well as one of our clinical dietitians, Ms. Julia Noel. We also have some awesome team members here with us answering some of your questions. So we've got Dr. Catherine Sumter, Sherry Ivy, Anna Heston, and Margaret Singer. And so we're going to kind of start by going over a few things you need to know. So we know that there are probably going to be some great questions, and so we want to be able to organize those well. So please use the question and answer section if you have a question. So it says Q&A. We are not going to be using the chat feature of the webinar just to keep everything nice and steady for the questions so that we can keep those in order in which we got them to be able to answer them. And just to let you know, because we have those extra hands that are helping us answer those questions, some of your questions will be answered as the presentation is going on, and some of them will be answered at the end as we have time. So just to let you know about those different features. Our objectives for today's presentation, we are going to review the standard 2020-2021 versions of the school care plans for Bonheur. And we're going to review the differences between our 4 main types of school care plans. So we have our Insulin Pump school care plan, our sliding scale, our fixed insulin doses, mixed insulin, as well as our insulin to carb and correction factor. And then we're also going to explain, and hopefully you guys can understand the differences between the different sections of our school care plans. And then we're also going to outline the parent responsibility in relation to the school care plan and the child's diabetes care. And so our first presenter is going to be Ms. Madison Greer, so I'm going to hand it off to her.
So the first thing that you will see on the school care plan is just a little title page. One thing that we have added is we are trying to specify the type of diabetes that the student has. So there is a line for that. A lot of times right at first we haven't yet determined what type it is. So you might see this say undetermined or unknown. Right at first before we've gotten those labs back that really reveal what type it is. We are going to fill out always the patient name and the date of birth. That's going to be on every single school care plan. We might fill in the school name, school fax, school grade if that's provided to us from the family. This section is not going to be necessary for that school care plan to be accurate or to be used. So if your student originally started at one school and they've gone to a different school, just because that old school name's on there doesn't make this invalid. So the big thing is just making sure that it's for the right student. The next section that you see in the school care plan is a listing of the supplies that need to be provided at school in order for that student to be safely cared for. So all of these things, except for that optional water bottle, are required to be provided by the parent. So if that student gets to school and at that time they're missing urine ketone strips, that's a necessary supply to safely take care of them. So we would not want them to be at school without that supply. So it's going to be very much the parent responsibility to bring that stuff to you. And if you're low on any of those things, we definitely want you talking to that parent. Sometimes with insurance coverage, they're going to have to carry that stuff back and forth. They might not have enough to just leave you a supply at school. So just be aware that sometimes we can do that. Sometimes it's going to need to go back and forth. You will see a few extra things on the school care plan for insulin pumps with supplies. So pump batteries, reservoirs, and infusion kits. Those little bit of extra things that are needed to make sure that that pump functions appropriately. Our next section is on the insulin regimen, but we're actually going to skip down to the hypoglycemia section because if you've seen a school care plan before, you know that very first line is if that blood sugar is less than 70, we've got to treat that low blood sugar first. So we decided to go ahead and skip down to that and cover it, and Erica is going to talk about that.
Just to take a step back, in your registration link or your reminder that was sent to you by Stacy Rawson back, I think it was yesterday, there were attachments at the very bottom of that where you could view both this PowerPoint and our different versions of the school care plan. We decided to send you those sample copies so that you could see our standard versions. Like I said, there's 4 versions of our school care plan. So if you didn't access those before now, you may just want to go back in your email and find that. And so it's going to be on that link. And it should be on the reminder link that you got an hour ago as well of the document. So if you're looking at that and just kind of curious, if you've never seen those before, then those copies are there within your email to view. So like Madison said, we are skipping down just a little bit, but we do want to hammer out this idea that we want to make sure that we treat that blood sugar if a child is less than 70 before a meal. It's a big question that we get along the way of if they're getting ready to eat, do they really have to treat with the rule of 15 or can they just eat their meal? And we always, both at home and at school, want those lows to be treated even if they're before a meal. So before the insulin is given, we want to follow this hypoglycemia protocol. So you'll see this in here and throughout the PowerPoint, we're going to go through if a child is symptomatic of a low blood sugar, and these symptoms may be something that the child is able to verbalize, and it may be something that you're noticing with that child, or a teacher is noticing, or another student is noticing, and the child themselves may not be able to communicate that they don't feel well. So on here, there's these signs and symptoms, and you can read those: weakness, shaking, sweating, hungry, sleepy. A lot of times our kiddos tend to say that they feel shaky, and then their caregivers tend to notice maybe a personality change or even a change in their behavior. So those are just things to look out for. The next part of this is that you want to notify the parent of a low blood sugar. And so that can be done however is agreed upon with the parent. So if that's that, you're going to send them a text message or an email, or you're going to send home a daily blood sugar log or a weekly blood sugar log. However you communicate that, please include that in the 504 plan for that child so that that's agreed upon how you're going to communicate those blood sugars, both high and low, as we go through this presentation. Something else that's in here is it says, do not leave student alone or send alone if we are concerned about treating a low blood sugar. Again, you school nurses and teachers and administration, you are the expert on your school and how it functions and how that child is going to function within that school. And so this is something that you're definitely going to have to address on a personal basis for that child to most safely take care of them. We encourage, as the best way, is definitely to have low blood sugar treatments in every single room that that child is in. If they're in an elementary school room, they may just mainly be in one classroom, but even if they travel in between or travel to recess, they definitely need low blood sugar treatments wherever they go. We also recommend that they have some way to check their blood sugar as well. And again, that's going to be different for our older kids versus our younger kids. So that really does need to be addressed in the 504 plan. But our best recommendation is that those children, wherever they go, they have some kind of low blood sugar treatment with them, whether that's that they're responsible for keeping it or the teacher is responsible for having it. That again needs to be addressed in the 504 plan. But very, very serious that they have those with them. Of course, we know that unconsciousness or seizure is possible if symptoms are not treated. We'll go into that a little bit more. So it's very, very, very important that everyone is on board with knowing how to treat low blood sugar. So anyone that is coming in contact with a child with diabetes. So every teacher, even bus drivers, like everyone just having that community to know how to treat these low blood sugars. And then we also know that we're using fast-acting carbohydrates should be readily available at all times and should be administered immediately if the patient is showing these symptoms. And we're going to go into those here on the next slide. So this is what we call our rule of 15. And so it's a standard way that we're going to be treating these low blood sugars. So you'll notice, I'm not going to read every word to you, but on number 1, if the blood sugar is less than 70, then you're going to need to treat the child with a rapid acting or fast acting 15-gram carbohydrate option. And there's some listed there. Not all sweet things are created equal, as most of you probably already know. And so we don't want to grab the first sweet thing like a candy bar or even animal crackers. We want to treat their low blood sugar with something that is a fast-acting carb to get that blood sugar up quickly. So if there's something that's outside of this that a parent is wanting to use, just research it together to make sure that that is a fast-acting carbohydrate option, and then you can address that in the 504 plan. Again, we want to repeat blood sugar testing every 15 minutes until the blood sugar is above 70. So that golden number is 70. And there are some examples of here as to what you'll need to do in different circumstances, and depending on how closely that blood sugar is to the next meal. So we do notice in bullet point 2 and C, if the blood sugar is greater than 70 and lunch or snack is greater than an hour away, they're going to need a snack with some carbohydrates and protein in it. So 15 grams. So there are a few things listed there. So that again is going to need to be communicated with the family as to who's responsible for both these low blood sugar treatments as well as these snacks to continue the rule of 15 in the case that we need to utilize this for the child. And we will need to utilize this. So definitely that great communication. And then number 3 says, if the student experiences loss of consciousness or seizure, administer the emergency low treatment to raise blood sugar. So we're going to go into those as well. So something new that you're going to see on every single school care plan for this year is that there are 3 hypoglycemia emergency options. And so as we go through that, I'm going to touch briefly on these. You're still mainly going to be seeing that glucagon emergency kit, which is what we've been using for years. And so with that, you'll notice that each hypoglycemia emergency treatment has a little bit different instructions. So just make sure that you're following those instructions for weight. That's why we put weight there, because it does affect the dose, especially for glucagon, and then Gvoke at the bottom as well. So we know that glucagon is made by a company named Lilly. And what we love about Lilly is that they've got great educational resources for you guys. And so if you want to learn a little bit more about how to administer glucagon, I know that we've got one new nurse for sure on here. You can go to the Lilly website, and there's a step-by-step tutorial that will talk you through it. I also am quite fond of the app that you can put on your phone, because Lilly has an app that you can download, I know for sure, to Apple and Android phones. And if you are in an emergency situation where you have to administer glucagon, you can pull up the app and it will talk you through every single step of administering glucagon. And that's really great for, again, additional support staff who may be on field trips or other things like that who aren't as familiar with it. Again, that's our emergency treatment. We definitely know that if we intervene early to treat these low blood sugars, we're most likely not going to get to this point where we need these emergency treatments. The next 2 options I'm going to go over again. The next 2 options, both Baqsimi and Gvoke, are newer on the market, and so very few kiddos are going to have this. Occasionally, some of our commercial insurance patients may have a free voucher or something of that nature to be able to get these. And so Baqsimi and Gvoke also have tutorials online that you can go to their website and watch their instructional video, and they're really great resources. Baqsimi is super cool. It's a nasal glucagon kit, and so this is only for kiddos if they are 4 and up, so you will notice that, which most of your schools probably don't have kiddos under the age of 4, but it's just a set dose, and it goes into the nostril, and you just kind of utilize that. So again, Baqsimi has that on their website. Gvoke is a premixed glucagon, and they have both a regular syringe and an auto injector, and so you can also go to their website to keep the most up-to-date videos of how to administer those. Please notice that on the bottom, the dose is a little bit different, so it's 0.5 milligram and then 1 milligram. So just kind of keep an eye on that with the dosing for those kiddos, and then just really communicate well with the family, because they may have one emergency hypoglycemia treatment for a certain amount of time, and then especially if they got a free voucher or something of that nature, then they may have to revert back to glucagon. So just have good communication with the family. They can use any of these. You can utilize any of these at school. One big thing as well is just make sure you check the expiration dates on these items, especially the glucagon. They tend to put that sticker right over the expiration date. So just make sure that everything is still in date with what the family is bringing you, or maybe what you have left over from school from last year before the kiddos went out. The biggest thing with this is if you administer any of these treatments, you're going to have to call 911 and of course communicate that with the parents as well. And so there's a few other things on there, but it basically has kind of lined out exactly what you need for this. And I'm going to hand it over to Madison so she can tell you more about the insulin therapies.
So we're going to start by talking about sliding scale insulin. About 95% of our newly diagnosed patients do start on a sliding scale, mostly for that simplicity as they are getting used to all the new tasks and behaviors that they've got to do with this new diagnosis. So a sliding scale is generally given at every meal, breakfast, lunch, and dinner. And it is based on a set amount of carbs, which Julia, when she talks about the meal plan, she's going to go into the reason why you might see some of those differences, but just be aware when you see that sliding scale most of the time in that meal plan, it's going to have a set amount of carbs that they need to be eating. And so at the very base dose, you're going to start at the smallest one, and it's going to go up by 1, 2, or maybe even 3 units for each blood sugar range. So the blood sugar range is going to let you know what amount of insulin to give based on that pre-meal blood sugar reading. We also list on the school care plan the basal dose of insulin. So most students are going to be on a 1 time a day long-acting insulin. Generally, this is given at night or in the morning before they're at school. If this is something that we recommended the school nurse assist them with and giving it at school, that's going to be something that we encourage the parents to speak with you about. Sometimes that's just going to increase that adherence, so we do work with them to see if maybe that's a possibility. So definitely talk to them if you notice on that school care plan that that long-acting insulin is said to be given while they're at school. Following being on a sliding scale, we do most of the time attempt to move them to a more flexible insulin dosing. So at the time that they do that, you're going to see the more standard school care plan that you normally see with the insulin regimen with a nutrition dose and a carbohydrate dose, where they're not going to have as much of those restrictions on the carbs. It's going to be based on what they're actually wanting to eat. So you're going to see what's called their insulin to carb ratio for that nutrition dose, however the 1 unit of insulin for however many grams of carbs that they eat. So this is based on that mealtime carb range. So whatever they end up eating for that meal is what they get dosed for. We do have some students that are going to be on half unit dosing, wherein they're a little bit smaller, maybe eating smaller doses. So we will have marked whether we want you to round to the nearest whole or round to the nearest half. At meals, we are going to also add a correction dose based on that pre-meal blood sugar. So they're going to give you a target. Generally, we see 120 or 150. So if that blood sugar is above target before eating, we know that we're going to need to calculate that correction dose. You're going to see generally the same correction dose throughout the whole day. So 1 unit of some form of rapid-acting insulin for every certain amount of points above that target. You will also notice that the whole unit versus half unit dosing, it's written on here twice. The reason for that is our standard of care for insulin dose calculations is to round each of these individually before you add them together to give that final dose. So we don't want to add the decimal to the decimal and then round at the end. We want to round each individually. And the reason for this is mostly just consistency. So once we have that consistent dose, we know that that rounding is always going to be affecting that blood sugar in the same way. So this is the way they're taught to do that at home. Something we added last year is some of the meters that we have, they have a certain maximum number that they can read out to. So we have put a high blood sugar number that you can use for calculations. So if that glucose meter reads high, our advice is to give a correction dose based on a blood sugar level of 500. We're also going to have that basal dose for this insulin regimen as well, and any other medications. Generally, those other medications we put on the school care plan are going to be diabetes medications. So if they're on something from a nephrologist, it's not going to be on their diabetes school care plans. It's going to be things like metformin or Victoza, especially for those type 2 diabetes patients. Another insulin regimen that you might see is a mixed insulin regimen. It's really important that we know what the names of these insulins are because this is just a little bit different kind of dosing. So a mixed insulin generally is made up of a more intermediate acting insulin combined with a rapid acting. So because of that intermediate acting insulin that's in there, they only get this medication twice a day. So they get it at breakfast and they get it at dinner. It's going to be based on the same amount of carbs at every meal, same thing as that sliding scale. And you're going to see something similar where it does kind of slide based on what that pre-meal blood sugar is. With this insulin, since we do have those intermediates and they do overlap, the rapid acting doesn't overlap. So the rapid acting they got at breakfast, by the time they get to lunch, it's not there. So you're going to see that we're going to have a correction dose of a rapid acting non-mixed insulin if they're on the mixed insulin. So at school, generally what you're going to see is the rapid acting standard Humalog, Novolog, Apidra, something that is just rapid acting, not mixed with anything else. And you're going to see them get a correction dose. So it's going to be based on the pre-meal blood sugar, still with that blood sugar of 500 if the meter reads high. And then the school care plan for the insulin pump is going to be very different in insulin dosing as well. So we do like to let you know just what type of insulin pump they're using. It's very important that the insulin pump be worn at all times. An insulin pump, it works by giving rapid acting insulin, and that is all it's getting. So if we're disconnected from that pump, we have no active insulin. So it's really important that we never stay disconnected from the pump since it's continuously providing that insulin. We will put in our school care plan what manual basal rates they're on. If you know anything about insulin pumps, you know that the newer versions have more automation, where they're maybe using some continuous glucose monitoring readings and they're self-adjusting. But every insulin pump, whether or not they're in that automation or not, they're going to have some manual basal rates. So those are going to be in each school care plan. And all insulin pumps currently, we do still have to trigger for it to give that mealtime dose of insulin. So we will be putting an insulin to carb ratio and a correction dose in the insulin pump school care plan. One thing that we want to point out is that very last line, provide nutrition and correction bolus per pump calculator by entering carbs and blood sugar in pump. So the insulin pump does take into account a few extra factors that we don't consider when we're on injections. So if you saw that student and you typed in their blood sugar and you typed in their carbs, you might come up with a different dose than what the pump is suggesting. And that is all right because it's taking into account some extra things. Another cool thing about an insulin pump you'll see is that we don't have any rounding rules because the insulin pump can give you a very specific dose of insulin. So that's just going to give what that pump says. And when I get to ketone management in insulin pumps, I'll talk a little bit more about what those factors are and why you're seeing a little bit different number. And so now we're going to hear from Julia, and she's going to talk about food at school.
We'll be presenting on some general diet guidelines for our students with diabetes. We will want to encourage not adding sugar or sweets to meals or routine snacks. The purpose of this for our families, when we have them come in for education in the clinic, we inform them of the way that a lot of our simple carbohydrates like sugars, honeys, and syrups can spike the blood sugar really rapidly. So we put in the school care plan not to add those specific types of sweeteners or snacks that have a lot of added sweets, just because of the fact that we know that they can spike the blood sugar pretty rapidly. We also recommend substituting fresh fruit instead of canned fruit, just since we know that a lot of times our canned fruit options and our fruit cups that have added syrups can also add sugar and maybe potentially have a greater spike in blood sugar for our students instead of just the fresh fruit option. So that's another recommendation. We also say no juice unless treating a low. We know that our juices are going to have a lot of that simple carbohydrate in the drink as well. And so we know that that's a good option if we're treating a low to get that blood sugar up really rapidly, like Erica discussed for the rule of 15. But for a drink, typically we recommend water or a non-nutritive sweetener added to water, or doing maybe a sugar-free drink just to make sure our kids aren't having a lot of that added sugar in their beverages, which can spike their blood sugar pretty rapidly as well. We also say do not withhold scheduled meals. We want to make sure that, especially our students that are needing regular meals throughout the day and also getting snacks at scheduled times, we want to make sure that we're not disrupting that medication and food interaction that their bodies will need while they're on an insulin regimen, along with some of their other medications that they could potentially be on. So we certainly want to stick to a schedule where they are allowed at least 3 meals a day. We know that's best for their blood glucose control, keeping their blood sugars in range. And this last recommendation, encouraging healthy food choices. We know that that's a recommendation that we would say for any student, regardless of whether they have diabetes or not. But the reason why we include this specifically is just to let you guys know that it's encouraged to make healthy choices, but we don't expect you all to enforce this. This is certainly something that we want all children to be able to choose healthier options. For the example here, white milk over chocolate milk, just since we know that there's less added sugar. So we just want to make sure you all are aware of that recommendation, but it does not have to be something that is enforced in the school setting, just as a reminder. So getting into the meal plan section of the school care plan, your students will have a little bit of information about how many grams of carbs are recommended for breakfast and lunch included in the school care plan. This number, if there is a number, whether it's 45, 60, 75, or some other amount, is really recommended based on 2 things. First, their insulin regimen, so that we are kind of working on making sure that they have a certain amount of carbs to go along with their insulin regimen to ensure that we are aiming for those in-range blood glucoses before and after meals. And it might also say carbs as desired or unrestricted if a patient does not necessarily need a specific target for carbohydrate intake at each meal. But just be aware that there could be a number or possibly another bit of information in that section, whether it's breakfast or lunch. And then we also include AM and PM snack for those students that do have snack recommendations. We typically will say 0 to 15 grams of carbs based on the fact that we know that most of our healthy snacks are probably going to be less than about 15 grams of carbs. We make sure that when our students are getting the meal plan, that they're aware of the need to kind of have a specific timing and spacing for meals, and that they will be allowed to have snacks if needed. The greater the snack amount in terms of carbs is kind of correlated to that meal timing and spacing. So just be aware that there could be varying amounts there, but generally speaking, we want to aim for less than 15 grams of carbs for our snack choices. In the next slide, we're going to talk a little bit about dosing insulin with snacks and maybe why that might be a recommendation for your student. And Madison and I will tag team that discussion as we get into that one.
So this is a newer section of the school care plan that we've added in after getting multiple calls about those special occasions where the parent brings in some birthday treats, and we really want our students with diabetes to be able to participate. So in the past, y'all were having to call us for that special occasion dose and get orders and new things, and it was just complicated for all of us. So this is actually a standard that we even teach our students and patients with diabetes to use at home to allow them to participate in those special occasions. Some of our patients do get insulin with all snacks. So we would mark yes if they're supposed to get insulin with every single snack that they eat. Just like Julia was just talking about with that 0 to 15 grams, just because they're getting insulin with their snack doesn't give them freedom to just go crazy and eat 30, 45, 50 gram snacks. It's still going to be based on that snack of 15 grams. They're just going to get some insulin for it. And so if we've marked yes, or if we've marked only special occasions, we are going to actually give you a dose of insulin to give with snacks. One thing that we do for snack insulin is that we give insulin for nutrition dose, not for correction dose. This is mostly related to that prevention of stacking of insulin. So since insulin timing. We know that if we are having a snack 2 hours after we ate, some of that rapid-acting insulin from lunch or from dinner is still working on us. So if we ended up giving a correction, we might overcorrect that blood sugar. So just we cover what we're going to have for that snack, and we are going to tell you exactly what dose to give for that. We at school, we do give you some guidelines. At home, we're going to teach those families a little bit more critical thinking skills about when those snack timings don't follow these recommendations. But at school, we're really going to want them to follow that recommendation. So Julia is going to talk about that.
So for the insulin dosing with snacks, as you can see here, it's very similar to what you would see for insulin to carb ratio for meals. However, be aware that for some of our students, the dosing for their snacks could potentially be slightly different from the dosing that they typically have with meals. So it's just something that we want you all to be aware of, to pay close attention, especially when there is dosing indicated for snacks and what that dosing will be whenever a child is eating snacks that requires insulin dosing. We also want to be aware of 2 recommendations based on when we would want to space out snacks that we are allowing the child to give insulin with. We want to recommend at least 2 hours before lunch, no more closely in terms of the spacing between that snack and lunch, just because, like Madison was mentioning, we don't want to risk insulin stacking because that child could be at risk for a hypoglycemic episode if they are getting those 2 insulin doses too soon. We say generally also anytime after lunch, we're kind of outside of that insulin stacking window a little bit more so than if we were to give that insulin before lunch. So anytime after lunch should be fine, especially when we are encouraging the child to take insulin with their snacks, especially if they need insulin with every snack. Another thing we'll add is just that, again, this is about inclusivity. We don't want students to feel like if there's snacks at school for a party or a school event or a holiday, that they aren't allowed to be a part of that event just because of the fact that the snacks that are available to them are more than 15 grams of carbs. So we do want to reiterate that this is just a part of helping them to feel a part of the group and making sure that they also have some options that they can choose from and be prepared so that their blood glucoses can stay in range whenever having those snacks that may require a little bit of insulin with them too.
So the Insulin Pump School Care Plan is going to be a little bit different. We do still recommend to only give a nutrition dose. With the insulin pump, we're going to just provide that snack bolus for the pump calculator by entering those carbs in the pump. If at that time we did include a correction dose, the pump's going to take into account active insulin and try and prevent that stacking. But our advice at school is to just put those carbs in. Don't worry about a blood sugar check at that snack time.
All right, so now we're going to get into blood sugar monitoring. And one thing that we should have said at the beginning is that we very much appreciate the partnership that we have with a lot of different school systems. I know right now on this webinar, we have a couple of different school systems, Carville and Shelby County and DeSoto, and they actually take part in our advisory council here at Bonheur. And so we definitely listen to the concerns that you guys have. And even in this section, as we're about to start, we have really compiled a lot of different phone calls that we've gotten and a lot of different suggestions from both school nurses, school personnel, just all the way around of how to best really word this to be able to meet your needs. And so we actually have changed a lot of our terminology with our new onset diabetes patients especially, and we are utilizing blood sugar monitoring as a standard of most of our education, especially in the beginning. So you will notice throughout the school care plans that things have changed to blood sugar. You will also notice that there are little pieces of the school care plan that have changed from last year and previous versions. Every single year, we sit down as a committee in March to formulate the new version for the upcoming school year. So in March, we sat down to talk about 2020, 2021. Little did we know that everything that would conspire, but I highly encourage you guys to look at every single section and make sure to read through it, because some little things have changed to better meet the needs of the students and hopefully clarify some things for both oncoming school personnel that are new to the system and the existing school nurses who have served our patients so well. So you will notice even within this blood sugar monitoring section that there are little things that have changed a little bit. So we're going to kind of go through that. So again, in this section, like I talked about earlier, when a child has a low blood sugar less than 70, as well as if they have a high blood sugar greater than 250, you're going to need to communicate that to the family. Again, that can be arranged by the school as far as how that communication is going to happen. Because you may have a student that is having some higher blood sugars or different things at different times. And so however you guys want to communicate that best with the family, it's not a need for panic. You've got your orders of how to deal with it. Just make sure you have that open communication with the family as to where you're going to address that. You'll also notice in this section we have that the student will monitor blood sugar data at the below times utilizing CGMs as available. I'm not going to go super in-depth on that because we'll talk about it on the next slide. But again, in a 504 plan between the school personnel and the family, you guys are going to have to figure out how you want to utilize a patient's blood glucose monitoring or blood sugar monitoring system, so their actual finger sticks with their blood glucose values and their continuous glucose values, because they work. So anyways, depending on the child, they may start off with one and transition to another, especially if they're newly diagnosed. It takes sometimes a couple of months to get them set up with that continuous glucose monitor. So they may start off with one system of monitoring their blood sugar and transition to using a CGM. So that's where that open communication is going to need to happen from that parent as well, because it is a partnership. And so we have also included in this section that the student should be allowed to carry their blood glucose meter or their continuous glucose, their CGM receiver or phone with them at all times, plus any necessary supplies to go along with blood glucose or blood sugar testing and emergency food. We've added the disclaimer in here that the student's ability level needs to be determined by the school nurse and the parent in that partnership with that 504 plan. So we've heard so many great ideas from families as well about how they stock every single classroom with the necessary supplies. It's not necessarily feasible for all of our students, so sometimes the teachers will actually pass a kit between them, especially if young children are swapping classes or going to music or PE or something of that nature. And so whatever works best for your school, for the child to have what they need with them at all times safely. Because if you have a kindergartner that has their Skittles with them, that might not turn out too well. So the teacher may need to keep track of those low blood sugar treatments and the blood glucose meter, especially if they're not able to check their own blood sugar. So when do we want the child to check their blood sugar? We've outlined this in this slide that you'll see. So daily before meals, when the child or student feels low or high, or if a teacher or other school personnel, school nurse is noticing that they have that maybe personality shift, or maybe they're really sleepy and we're concerned about them, and they're exhibiting those signs of high or low blood sugar, then we want to check that blood sugar. And then like I said, and then before PE or exercise. We have heard many concerns about this that we've included. And so Julia's going to go over a little bit more about, especially this question of what if a mealtime is really close to that exercise or PE or recess? What do we really do with that? My best suggestion is that you guys, in partnership with the parent, have that open communication with the parent. I know that things are changing rapidly and you guys are working so hard. So I know that even recess and PE may change quite frequently. So it's not a typical school setting, but Julia's going to give a little bit more information about that, but each child's a little bit different. But definitely addressing in the 504 plan, we get lots of questions about school trips and bus rides and just different things of that nature. All those specific things really need to be addressed in that 504 plan as well, because every child is different. If they're a car rider, or if their bus ride is only 10 minutes, or if it's an hour and a half in a more rural area. I know that we've got some more rural schools. And so definitely having that open and honest communication about what that's going to look like and how feasible your school is going to be able to implement that care on a daily basis for those children. And so those are things that we haven't addressed here. And so one thing we want to let you know is this is our base for blood glucose or blood sugar testing. So we don't want to compromise these recommendations. Again, we'll talk a little bit more about exercise in a minute. But if there's something in addition that it wants to be added, then we can always add something in addition. We just don't want to take any of these away. Just keep that in mind as we go through this. Our next slide is about our continuous glucose monitors. We have spent so much time trying to figure out how we present this in a standardized way. So we've got a few parameters. What we want you to know is if a child is utilizing any form of technology, and if a family is utilizing any form of technology, whether that be an insulin pump or a continuous glucose monitor. So sometimes parents won't say continuous glucose monitor, they'll probably say either Dexcom or Freestyle Libre. Those are the two main ones. There's also a Guardian Connect with the Medtronic system. So their wording may be in the Dexcom or the Freestyle Libre, but those are continuous glucose monitors. And so if they're utilizing any form of technology, they really are going to have great communication with all parties that are going to be caring for that student, so that everyone is on the same page as far as how you want to utilize that technology and who's responsible for helping with that technology at school. And so that's going to be very dependent on your school system and how you want to implement usage of that for that specific student. So you'll notice in here there's some general options for decisions regarding the use of CGM for treatment of blood glucose values. You're going to have to address that in the 504 plan. We definitely want everyone to respond to a low blood sugar. So again, that's going to be less than 70 from that continuous glucose monitor, and follow that hypoglycemia protocol. And then of course we want to respond to a high blood sugar greater than 250 if 2 hours after a meal. The reason why we put that in here is because we naturally know that a child is going to have higher blood sugars after they eat. Anyone's going to have a higher blood sugar after they eat. So we want to make sure that we're not trying to intervene too soon, and that we're really intervening appropriately. This is also you're also going to notice a little bit higher blood sugars, especially if you and the parent decides to post-meal dose. I'm not sure if we talked about that a little bit, but again, whether we do insulin before we eat or after we eat, that's going to need to be addressed in the 504 plan as well. Our clinic definitely promotes that pre-meal dosing, but if that's not possible for school just because of logistics, then we can address that in that 504 plan if it needs to be an after they eat kind of thing. But if their blood sugar is 250 after two hours after that meal, then we're going to follow the hyperglycemia protocol, which we're going to cover in just a minute. We also want that child to have access to their CGM receiver at all times. Okay, so we talked about the different kinds of continuous glucose monitors. The Dexcom especially can be utilized from their phone as their receiver, or as kind of the item that's going to be able to tell them their blood glucose value. And that's how they're going to be able to utilize that. And some of them can even use an Apple Watch as well. So each school is going to have to determine how that technology is utilized at school, and any behavioral concerns that come with if a child uses a phone for another reason other than for their Dexcom information or for their continuous glucose information. But they do need those devices to be able to utilize that. A side note, one school nurse decided that there was a child who had a disciplinary problem with their phone, and so they ended up, like, on all of his desks putting pieces of tape in a rectangle, and that's where the phone would sit in all of his classes. And then his phone was handed off to the different teachers. So anyways, awesome problem solving by great school personnel, but you guys are going to know those students best to be able to really figure out how you're going to implement those things. Again, special accommodations related to data sharing, calibration, sensor replacement need to be determined by the school nurse and parent as specified in that 504 plan. If there's an issue with the CGM, patients still are going to need to have blood glucose testing supplies as well, and may need to utilize those, especially if there's an issue with their continuous glucose monitor. And I'm going to hand it over to Madison now to talk about hyperglycemia. Tends to be the favorite section.
Everybody loves a good high blood sugar, right? So some signs and symptoms that you might see with high blood sugar, we do have those listed here. The one that I really want to talk about is vomiting in high blood sugar. So that could be a dangerous sign in someone with diabetes, really indicating that they might be in diabetic ketoacidosis. So right here, it does say, check blood sugar and ketones. So even if you aren't aware that that blood sugar is high or that we have ketones, anytime they vomit, you are going to think, okay, maybe this is related to having those ketones. A lot of times if something else is going on, like flu or stomach virus, that student might vomit and might have ketones, and they might have a normal in-range blood sugar. So it's not something we're going to be surprised by. We just do know that vomiting could be, okay, let's go ahead and get started checking and seeing if this is a ketone issue. So we have changed the wording of that very first line of the hyperglycemia instructions. If blood sugar is greater than 250 and student has not eaten in the past 2 hours, check for ketones. Main reason we do that is for that CGM, like Eric was talking about. It's going to show us what that blood sugar does after the meal. We know the first couple of hours it's going to go up. It's going to still come down from a lot of that insulin that was given for breakfast or for lunch. So we've added that in there so that you don't feel like you've got to, every time that CGM says 250, run and check for ketones. We're going to space that really the 2 hours after the meal. We want to notify the parents anytime their child has ketones, something we really want them to be aware of. We are kind of preaching that a lot in this webinar is communication with the parent. We really want them to take an active role in the way the diabetes is managed at school and in their communication with you. Because the more they communicate with you and the more you're able to talk with them, the better it's going to be in those times where things fall a little outside of the norm. So if you are checking for ketones, blood sugar greater than 250, 2 hours out of the meal, if ketones are negative, then we're going to just not worry about rechecking ketones, rechecking blood sugar. We're just going to treat that student as usual with that insulin and the insulin regimen. If it's mealtime, if it's not mealtime, we're just going to continue on our way because we don't want to do anything extra if we don't have those ketones. If trace or small ketones are present, we do want to allow the student to remain at school. Our goal is to keep students in school as much as possible. Or I know now it's a little bit different, but when we're in person at school, we really want them to be there. We don't want diabetes to be keeping them from coming. So if we do have trace or small ketones, what we are going to do is we're going to administer insulin according to the blood sugar correction dose that's found under the insulin regimen of the school care plan. If you think back to when I was talking about insulin regimen, a couple of the different school care plans might not actually have a correction dose listed. So in the sliding scale, most importantly, that one's not going to have a correction dose. So in the hyperglycemia management section of the sliding scale school care plan, we're going to give you a correction dose to use. The important thing to know about this dose is the family is not going to know what this means. This is just for your benefit. At home, that student or that family, they're going to call us and we're going to give them exact directions of what to do. They don't know how to do this yet. So just be aware they might not know what that correction dose is. The insulin pump school care plan is going to be different as well. A lot of the times with the insulin pump, the reason we have ketones is due to some malfunction of the pump or the infusion site. So we always want to troubleshoot what's going on with the insulin pump in the case of ketones. Always just kind of check and see if there's any very obvious thing going on, like we see the sets hanging out of the bike. It's not even in. That's going to be pretty obvious that the set's not working. But if you don't notice anything different, we just have that high blood sugar, those ketones, we want to check and see if the insulin pump is working. The way we do that is we give that correction that the school care plan is calling for. And even though we'll see later on, the recheck normally is 2 hours after that correction, on the pump, we want to recheck at 1 hour. Because if that blood sugar has not gone down by at least 50 points, we're going to assume that that set is not working. So we don't know how much of that previous dose they received. So we're going to give an insulin injection with the actual syringe using that blood sugar correction dose. And we're going to need to get that pump infusion site changed. This is another thing that we encourage the families to discuss with you in the 504 plan is who's going to change the set at school. A lot of our kids, they can do that set change by themselves. Some of them, the parents do all of it for them. So it's going to be something that they need to talk to you about. If that's something that they can train you in, that you feel comfortable with, or are we going to have the parent come to school? We really want to determine that before the situation actually happens. Of course, if at the 1 hour recheck that blood sugar has gone down by at least 50 points, we're going to assume that the set's working. We can continue to use that insulin pump to manage those ketones, continue to provide our sugar-free fluids, and do that normal 2 hour recheck after that first correction dose. So over the 2 hours after that first amount of ketones is detected, we're going to encourage them to drink extra sugar-free fluids. Over those 2 hours, at the end of the 2 hours, we're going to recheck for ketones and recheck the blood sugar. So at that 2 hour recheck, we see that any ketones are present. We're going to advise that the student must go home regardless of the blood sugar value. If at the 2 hour recheck, that previous treatment got rid of those ketones, they don't have any, we can have them remain at school regardless of the blood sugar value. So the example I would think of with this is we, at the 2 hour mark, still have small ketones, but the blood sugar is 143. That seems like a good blood sugar, but those ketones haven't gone away. So they still are going to need to go home with those ketones. Whereas they might come back 2 hours later and they're negative, but their blood sugar is still 300. They can stay at school. The ketones are the determining factor of if they can stay at school. If at any time you check ketones and they are moderate or large, we are going to advise that the student go home immediately. We will have you go ahead and give a correction dose of insulin just to go ahead and let that start working to help with the ketones, but we're going to call that parent and they're going to need to come pick them up. So this is something that parents should be aware of, and we are going to support that patient going home if they've got those moderate or large ketones. An important thing to remember with high blood sugar in students is they're going to need to go to the bathroom a lot, and they're going to need lots of water or sugar-free fluid. So we want to allow them to go to the bathroom and get unlimited access to water. Anytime a student has ketones, we're not going to allow them to play or exercise. And Julia is going to talk more about that in the physical activity section, why that's important. In the past, in this section, we either advise you to call us or that you can call us. We are not requiring you to call us. If you feel like these orders are working and you're doing them and everything's working according to those orders, you don't have to notify us at all. If you are looking at it and it doesn't really make sense to you or something a little bit out of the ordinary is coming on, you can call us and we want to be available to you. It's just not going to be required for you to call us. So Julia is going to talk about physical activity guidelines.
Okay, so for physical activity guidelines for our students, one of the most important things that we want to reiterate that is incredibly important prior to physical activity, whether it's PE, strenuous exercise, or recess, is checking the blood sugar just to see what that child is trending or what that child's blood sugar is prior to start of exercise. Erica mentioned that when it comes to checking blood sugar, sometimes there can be some exceptions for this, and one exception could be if a child has eaten a meal in the last hour or so, and we are needing to check their blood sugar before exercise, you can actually utilize that pre-meal blood sugar check in order to keep from having to check that child's blood sugar via a finger stick. Again, if they do need a finger stick prior to start of exercise. So that's just one time in which you don't necessarily need to do another finger stick if that child has just eaten and we know that their blood sugar was a certain number prior to that meal and they're about to exercise. If the child is symptomatic either with hypoglycemia or hyperglycemia, We encourage doing blood sugar checks during activity, but there are some specific guidelines for when that child does start physical activity, what we want their blood sugars to be, and what to do in different situations depending upon their blood sugar. So if their blood sugar is below 70, again, we want to activate that rule of 15 that's indicated in the school care plan and begin to treat for that low blood sugar prior to allowing activity to begin. If the blood sugar is less than 100 before exercise, we encourage giving a 15-gram carbohydrate snack. An example of this could be a small apple or graham crackers. And with this, just to kind of backtrack a little bit from our discussion related to snacks, whether parents are wanting to have snacks stay in the classroom or with the school nurse, that's something that will kind of be discussed specifically for that child in the yearly 504 plan. So we want to make sure that if parents have specific suggestions or preferences with where to keep snacks and those things, we want to make sure that the family has had the opportunity to communicate that with you all via the 504 plan. When blood sugars are above 250, just as we mentioned, we want to make sure that we are checking for ketones because we don't want to allow the child to play or exercise when ketones are present. The reason for this is that we know that certain types of activity at times can potentially cause an increase in ketone production, and so we don't want to risk a child starting out with ketones and then engaging in that activity and put them at further risk. Sometimes families may have slightly different preferences from what's indicated here in this list. That's totally fine as long as we are still adhering at least to these recommendations. We certainly don't want to take a recommendation and make it less strict. So if a parent is saying, hey, my child, she exercises with ketones all the time and usually she's fine, we certainly don't want to go with that recommendation because we know that it's the safest for that child to adhere to these guidelines. If a child's parent wants them to have a blood sugar of 150 instead of 100 before starting physical activity, that's just another example of a specification that might need to be indicated in the 504 plan for that child. But we will say it's usually good to kind of err on the side of more strict rather than less strict when it comes to children and checking blood sugar before physical activity, just to make sure that all of our children stay safe and that we aren't putting anyone's child at risk for any emergency event in relation to that. I will hand it over to Erica to talk about parent responsibility.
All right, so our last section in our school care plan is parent responsibility section. And so we tell the parent at every single appointment or every single class that they are responsible for keeping the school informed of any changes to the student's diabetes treatment plan or their overall health. And one of the key things with this that you need to know is that every time a child's insulin regimen has changed, so they come for a clinic visit and they happen to be seeing Dr. Sumter and she changes their insulin to carb ratio, we're actually going to give that child a brand spanking new care plan. We give them 2 copies and we tell the parent, it's your responsibility to save one of these copies for your file and then sign one and you need to send that to school. And so if a patient is inpatient, they're newly diagnosed or they're in the hospital with DKA, they are given a school care plan if anything changes or if they're a new patient. And so it's their responsibility then to get that school care plan up to the school because they're always given copies of that school care plan. The same goes if in between a clinic visit and a child needs an insulin change and the parent sends in a blood sugar log and we review that and we make an insulin change even in between their visits. And we are creating new school care plans and sending those to the parents. One great feature that we have here at Bonheur now, something called the patient portal. And so especially with everything going on with COVID and just restrictions on our campus, we are very much utilizing that patient portal to have great communication between our patients and their families and our clinic. And so we can actually create a school care plan and send it to the parent via that patient portal. They can save it as a Word document or PDF on their computer and then email it to you if needed. And so there's so much more availability to get that information over to you, or however you guys want to communicate that. But it is that parent's responsibility to do that. I know in the past, just because parents have not gotten you guys the information, we have done tons of faxing of school care plans the first couple of weeks of school. We definitely are not going to ever reject that request, because we know that you guys are doing the best you can to get things taken care of for your kiddos. We completely understand that, but please know that if we fax you something or if we send you something, then you absolutely are going to need the parent to complete this section. To actually complete the school care plan, to say that they're on board with these orders, and then also they'll need to work on a school care plan. There's another piece in this that says if the school requires, parents are responsible for sending an excuse for absences related to the student's diabetes or to his or her school. If the patient comes for an appointment, they get a school excuse. If they come to a diabetes class, they will get a school excuse. But if the child is missing school because they are sick or ill or following sick day rules or something of that nature, then that parent is going to need to make sure to send a note to the school in the same way that they would if the child was ill with some other illness. And so we do put that in there because sometimes the families especially will call us asking for school excuses, and we never knew that the child was sick from 3 months ago. And so we just want to make sure to kind of reiterate to the parents, oh, well, actually, look what Bonheur says. It says that you guys are responsible for sending these notes to us, just so that everyone's on the same page. And again, in this section, you'll see where it says a school nurse or personnel or parent and guardian will jointly assess the student's ability and responsibility to truly carry out their daily diabetes care, whether that's checking their blood sugar, utilizing their CGM data, giving their insulin doses. Just because a child seems like they are able to do that, a lot of times our teenagers especially, they need a little bit of extra help in supervision to make sure that they are adequately administering their insulin, checking their blood sugar, checking their ketones. And so want to make sure that everyone is on the same page with who is responsible for that care. No matter the age of the child or what school they're in, elementary school, middle school, or high school. And then, of course, there's a section here that the parent or guardian verbalizes understanding of the school care plan. Every single time that there is a change in the school care plan, our nursing staff or education staff is going over those changes with that school care plan that they're handing that family. So every single time they get new orders, the family is going to be aware of those new orders. And so just have that in mind. The last section is going to be our kind of the part that the family needs to fill out. You'll see the first couple lines where it says provider, signature, and date. This may be a little bit different than you've seen before. So we'll always type out the doctor's name who is actually ordering these insulin doses, or the nurse practitioner's name. And then you may or may not see a signature on this line. We are super, super excited that we are going to electronic school care plans across the board for all of Bonheur. So starting in the next couple of weeks, we will be able to have the same format of a school care plan, both on the inpatient side, so those patients who are newly diagnosed in the hospital or who have been readmitted for DKA or some other purpose. They, in the next couple of weeks, will have the same version of the school care plan as the patients that are seen on the outpatient side in this pretty format. So as time progresses, especially this year, you will no longer see those carbon copies written on. There may be a few patients who still trickle in here in the first couple of weeks who have those, but you will notice that those are going to be phasing out as we have worked very, very hard on those electronic school care plans so that there is consistency for the school system. So we're very excited about that. But with that, we have included what's called an electronic signature. So you may see a physical signature on these sheets, or you may see an electronic signature where it says electronically signed by Dr. Catherine Sumter or Loretta Smith, NP. So you'll see those on there as well. So just kind of keep an eye out for that. We're not going to send anything to you that is not appropriate and appropriately handled by our team. And as well, here you've got our telephone number, our general line for general requests, as well as our fax number. Just one thing really fast is that a lot of times, sometimes we'll get logs from schools. I highly recommend you guys communicating well with the parents and giving those logs to the parents, because if there's an issue with the blood sugar at school and you're wanting to send in those logs for us to review, we're unable to make any insulin dose changes without the logs from home as well. And so definitely making sure that those parents have those logs for upcoming appointments and communicating that with them. But if you fax it over to us, unless we have the parents' information as well, we're not able to adequately make any changes in between appointments to that child's regimen. You'll notice as well the section that is the parent responsibility. There's a new disclaimer on that that says the section below is to be completed by the parent or guardian prior to giving a copy of this document to the child's school. We again are reinforcing to that family that we need them to fill out this information, because you guys need to know how to contact these families. And so they will need to fill all of this out. You will notice at the very bottom, it gives an option for hospital of choice. And so we definitely need the parents to fill this out. It's up to them, especially for our students. I know on here we've got some students from Jackson, and some different counties. And so where that parent wants to send that child, this part we did want to touch on a little bit, because we've had a few schools call us to discuss this. Of course, if you are needing to, if you're very concerned about a child, whether hypoglycemia, hyperglycemia, or maybe an issue unrelated to their diabetes, of course you want to first try to contact their family. In an emergency situation, though, we definitely want you to talk to your administration to figure out how you guys want to handle that situation, especially if you can't get a family on the phone. Our fear is that if you try to call us to help triage that, there may be some time that's lost in those conversations. So definitely talk with your administration, talk with your principals and things of that nature, figure out how you want to handle an emergency situation. If a child does need to go to the hospital or something of that nature. So we just wanted to explain a little bit about that. A few other things, just as we wrap up our presentation, is we've just presented the standard versions of our school care plan for the 2020-2021 school year. We highly, highly recommend you going through, making sure that you're reading all of the sections. You will notice that at the top of every school care plan, it should say 2020-2021. And so if a child is trying to bring you, or a parent's trying to bring you a school care plan that does not state that, then you may not have the correct version of the school care plan, and you'll need to let the parent know that they need to contact us to be able to check in for that. And then please read all of the sections. For the most part, these are the standard sections for all of our patients. There are a few circumstances in which a patient's care may deviate slightly for specific reasons. We've addressed many reasons in this presentation of things that need to be addressed in a 504 plan. A few accommodations that may be a little bit different in a school care plan is if there is a medical reason for a deviation from the school care plan, such as a patient on a G-tube who may need a different rule of 15 just because of how it's going to affect them. And so that would be a very specific thing. We had one yesterday that Madison was working on, that a patient who was newly diagnosed and is honeymooning, and for just a short amount of time is not needing insulin, just due to that honeymoon period. And so we're still wanting them to do blood glucose checks, because we know that they are going to need insulin again soon, but their school care plan for that season is just very different. So make sure that you're reading through these to make sure that you're on the same page. Another thing is that children who are newly diagnosed with diabetes, for the most part, are going to start out on a sliding scale of insulin, which Madison showed you in the insulin regimen sections. And then hopefully within the first month to 2 months of diagnosis, they're going to be transitioning to that insulin to carb and correction factor dosing. So they're going to have a new school care plan to bring to you. So again, that's that communication with that family of, hey, have you had any dose changes? Hey, I know you went for a doctor's appointment. Did anything change? Those kinds of things. Just because a patient comes to a doctor's appointment or to a clinic visit or anything of that nature doesn't necessarily mean that their doses are going to change, but it is the parent's responsibility to bring those updated school care plans to them. I believe that this is all for our presentation. We are so glad that you guys were here to actually listen to us, to Madison, Julia, and myself, we actually are going to go ahead and work on some of our questions now. We do have to end this presentation promptly at noon. So we're going to go ahead and start working on questions. So I know our team has been working through those. If they have any that they would like to present for us some answers. So we'll just take a second to look at those. If you've got any questions, go ahead and ask them in that Q&A section so that we can get those answered for you.
So can you guys mute yourself, Erica? Okay, sorry. So the first question that came up during the session, can you, yeah, thank you, sorry. We're having some technical issues. So there was a question that came up just to clarify, and you guys may be able to see this in the Q&A panel. The person wanted to be sure that when we're rounding, we want to round the correction and mealtime doses separately and then add them together. I guess the sound glitched at that point. So that's correct. We would want to round the correction dose and the carb dose and then add them together. Another question that came in was just the question about any guidance for sports separate from PE. Would we have them check blood sugars more frequently or only if they're symptomatic? So this is really pertaining to when they may be after school with coaches. So I'm going to let y'all address that. Erica?
Address this question. For children that are involved in sports, typically what we recommend is yes, if you all are doing the finger stick option to check blood sugars, we certainly want to make sure that we are checking if the child is experiencing any concerns of high or low blood sugars. But we also recommend approximately every 30 to 45 minutes of physical activity that we allow the child to have approximately 10 to 30 grams of carbs to make sure their blood sugars are in range. So that can kind of help troubleshoot some of those concerns with maybe a child experiencing lows during sports. I know some families do kind of go ahead and make sure that they have things on hand during sporting events. Talking to the coaches about times when their child might need to kind of take a break or a timeout just to be able to have a little bit of maybe like a G2 Gatorade or a small snack that they can tolerate during physical activity. So there might be different things that each family prefers to do. That again is maybe something that would need to be covered in the 504 plan if a parent has very specific guidelines as to how they want their child to receive blood sugar checks or snacks to kind of help balance their blood sugars during activity. Another thing to kind of be aware of is a lot of times these children may need a sack with specific things to keep on hand. So in our classes in the clinic, we talk about making sure that the child always has a blood sugar meter, ketone strips, snacks for lows, water, or like a sugar-free drink, and then also possibly even like a sports drink that the child can use as a way to kind of keep their blood sugars in range. And then also a treatment for lows and then a balanced snack too. So there's lots of different ways that families might decide to kind of check on this, but just be aware of for a lot of our kids that are involved in sports, that's a great time to communicate with the family. I'll let Erica also add in her suggestions pertaining to this question?
I think one of the big things is just communication. As much communication as we can have. I can't tell you how many times we've had, especially teenagers, who their coaches have no idea that they have diabetes. So it's definitely going to be this huge communication with the whole school of what's going on. And it may not even be a coach. It may be a kid that's in marching band. I was a marching band kid, so I know that those kids definitely are going to need some accommodations as well. A big thing that we've noticed great success with is if a team has a manager, so even a student who is helping with water and helping with just making sure that everybody timing-wise is doing what they're supposed to be doing, that's a really great person to utilize in this role to have really good communication. You know, hey man, here's your snacks. Hey, I've got, you know, your Gatorade. Here's something special for you. I know that, you know, with your wrestling and your football, you may have those extra people, but it's who you identify. Another huge thing, especially for our athletes, is just communication. Just having that communication of at least telling a couple of their buddies or a couple of their teammates that they have diabetes so that people are looking out for them. We definitely want to, we encourage throughout our diabetes education classes to have healthy coping. And it's definitely part of that healthy coping. They can't help that they have diabetes. They just need a few extra things to keep them healthy and safe as they exercise and as they are an active teammate. If they can't adequately control their blood glucose, then they're not going to be the best teammate or the best athlete. And so as the team knows that, they want those positive outcomes for their teammates. And so definitely just kind of having everyone on board, the more people who are there to support that person, the better. But just definitely good communication, having good plans in place. And so that's all I have for that. We'll go ahead and tackle the next question as well.
So the next question is about continuous glucose monitoring. So it says under blood sugar monitoring, you have the student will monitor blood sugar data at the below times utilizing CGM. The question is a clarification. Before recess or PE, do we go by CGM or do a finger prick to verify if CGM shows blood sugar is 100 or below or 250 or above? The parent is wanting to utilize the CGM and decrease finger pricks whenever possible. Good question.
Okay, so let me get the question pulled up just to make sure I answer this appropriately. I know that each school is a little bit different and each child's schedule is a little bit different. We definitely know that the CGM data is an incredible resource, but we also know that it can be just a tad behind the actual finger stick value. So there are pros and cons to both methods of utilizing the blood glucose data. And so we want to make sure that, again, there's that communication. You know, a lot of times the families really love the continuous glucose monitors because they are advertised as no finger sticks. But in the fine print of those continuous glucose monitors, you're still going to be utilizing finger sticks if we are concerned about those blood glucose values. And so we really want that to be an open and honest communication between the school personnel and the parent as to how they want to manage those events. I know that Carterville Schools is on here, and we had some really great conversations with them, and they developed a plan for a patient with a lot of special needs as far as what really works best for that patient and how they want to utilize CGMs and what they feel is best. And I know that they took those concerns that they had to that parent and they formulated a solution, and it was a beautiful thing. So as far as that goes, does anybody else have anything they want to say about that? I think it's honestly going to be a joint effort and figuring it out on the front end of how you want to utilize that. But you still have to have some problem solving when it comes to utilizing the CGM. I'm going to let Madison pop in just to kind of give her opinion as well.
So I wanted to talk about that just a little bit. I think that CGMs are an amazing tool that our families can use, but under that impression, they're still not perfect. There are going to be some days where it just doesn't seem to be working right, especially right at the beginning. That first 24 hours of using a CGM, as it's getting used to your body, it can be a little bit more off. And that's why I would want to definitely have that really open conversation with the parent, just like Erica said. They're going to know these things. When I'm training someone to use a CGM, I always tell them that right at first you might not be super comfortable with just using the CGM. You might want to clarify with a blood sugar check until you feel more comfortable with how accurate that is and at what times it's not accurate. So I speak from experience a little bit in that I wear a Dexcom CGM. The first day, I don't trust it. I check my blood sugar, but that's something that I figured out with you. So talk to them. They're the ones using it. They're the ones that are going to know, hey, yeah, most of the time when I look at this thing, I'm going to just trust it. I usually, after that first day, I don't check my blood sugar again until the next one. So it's really figuring out what they've seen and how they've seen it work for them. So having that communication, and if they really trust it and they think that they can use that instead of the blood sugar reading, they probably do know. They know that that thing has worked and that it proves itself. So they're going to be the smartest ones about this. They're going to really be the expert on how things work for them and their diabetes.
All right. Do we have any other questions? Would you guys like to send in any others?
Hi, Erica.
Hey, Sherry.
It's on. Hey, Erica, quick question. Some questions that sometimes comes up is if a child starts to eat before a school nurse checks the blood sugar and they're on insulin to carb ratio, should they have the child stop eating, check that blood sugar, or just cover for the carbohydrates?
Kids never do that, right? One of my favorite, I'll diverge for just a second. When I was brand new to this clinic, one of my first phone calls from a school nurse was that a kid ate like 36 donut holes and didn't tell anybody. So that's definitely one of those things that is a behavioral option. So it's a tricky one. And the only thing I feel like you can really do, and guys, you butt in if you want to, because this is really a judgment call. I would definitely call the family and tell them what happened, because that is kind of something that we're going to have to work out. You know, was this a behavioral thing that the child did? Was it a behavioral concern? Or was there some confusion? Because again, you guys are heading into very uncertain times, and so things are probably changing daily. We understand that. We nurses know that. And so, you know, I would say my best recommendation is they definitely are going to need insulin for every bit of food that they have eaten and are going to eat. As far as the blood sugar, it's going to be skewed at that point. And so you don't want to check the blood sugar in the middle of a child eating and dose off of that necessarily, because it is going to be higher, and they could potentially get a lot more insulin. Do you have a suggestion that you're going to give, Julia? Yeah.
I was going to add that I know sometimes this is probably really difficult to tell, but if a child has been eating for less than 15 minutes, sometimes it's good to go ahead and give the insulin just based on that blood sugar, because we know that usually carbohydrates that are consumed are going to be probably affecting the blood sugar within about 15 minutes of that initial start time of eating. So as far as kind of an approximation of maybe when the child started eating and trying to figure out, okay, did they start eating, you know, within the last 15 minutes? Is it okay to kind of go off of that blood sugar before that point? It's probably going to be fine if it's been less than that time. After that time, again, like Erica was saying, it really is a judgment call, definitely communicating with the family, especially if there's a behavioral concern. But we do kind of want you guys to know not to necessarily panic. It is a one maybe time thing that we hope that we can kind of troubleshoot and prevent from happening again, but just be aware of maybe timing if possible, and knowing that sometimes when it comes to the way the body utilizes different nutrients, if we can kind of get within that 15-minute window, it's probably going to be okay for everybody.
How cool that we have a lot of great minds to think on these kinds of things. Our patients have access to our clinical dietitians. So Julia's one of those, and we have 2 other dietitians, and we're immensely thankful for their role. I definitely would say, as a child starts a new school, has a new school year, that you guys communicate all of the logistics of that patient getting to lunch and getting their insulin and getting their food, because some children, they go to the bathroom before they are going to lunch, and some of them, stand in a really long line. I went to a big high school, and you have to stand in a really long line to get your lunch. And so do those kids need to go to the front of the line because maybe they've gotten their insulin and they need to eat quickly after they've gotten that? And so all those little specifications, just kind of talking that through, because the logistics of how that child gets from the classroom, either to the school nurse or to the lunchroom, and when they eat, all of those little logistics, minutes matter. And so definitely kind of having that, and even walking that together, maybe walking their route together to figure out what adjustments you want to make. Some schools have let their diabetic kiddos go first in line in the lunchroom. And then that also is that open and honest communication of, do we dose for insulin before or after they eat the meal, logistically, with how the child is going to maneuver from place to place. We, again, in our clinic, recommend pre-meal dosing, so getting that insulin before they eat. But we understand if for safety reasons, we need to make sure to do that at a different time, especially maybe with our little kids under the age of 7, if we have no clue what they're going to eat, picky eaters, things like that. One other thing that I want to mention, though, with this is the child still, even if they're not going to get their insulin before they eat, they still have to have a blood sugar value before they eat. And so hopefully that answers that question. I'm not seeing any other questions, so I don't know if our team members, Dr. Sumter, Sherry, Anna, or Maggie, have any other things that we hear a lot. A lot of the changes in our school care plan have come from the phone calls that we get from you and the feedback that we get from you as schools and school nurses. So we definitely appreciate that. And we try to incorporate a lot of things within this version of the school care plan as well. Anybody have any ideas? Madison or Julia, do you have anything that you can think of? Alrighty. So I believe if no one else has any questions, then we have had a fantastic school nurse update webinar, or just school update. We just want to let you know from here with the diabetes team at Bonheur, we definitely highly appreciate all of our school personnel, all of our school nurses. We thank you so much for advocating and for just taking care of our diabetes patients and all of the kiddos under your care. We know that you've got a road ahead of you, and we're very proud of all the school systems and how you guys are handling the safety of all of the students during this time. I see my chat going on, so I want to make sure I don't miss anybody with anything. But we just wanted to let you know that. And if you guys have any overarching big questions that you still have questions about, you can definitely call us, let us know. We definitely want to refer anyone who didn't get to attend today to this webinar. So our goal is to hopefully get this up on our website. And so you will notice if you go to bonheur.org and then you go to services and specialties, that is the endocrine division. So once you click on endocrine, the diabetes is part of that. And at the very bottom, there will be resources and education pieces. One other thing I did think about as I was standing up here is when it comes to hyperglycemia, just a question that some of the families may have is that to manage ketones and manage what we call sick day rules at home, they have a more rigorous set of parameters that they're using called our sick day rules. And so those are just for home use. Everything when it comes to hyperglycemia and ketone management at school is included in the school care plan. So if they try to bring you a chart that's got some pretty colors, it's green, yellow, and red, that is only for home use just because it's a little bit more intricate as far as how they're managing those sick days at school. Before I close this off, I'm going to double check one more time to make sure we don't have any questions and answers. And like I said, we hopefully will get this uploaded to our website so that other staff can utilize this at other times. We appreciate your flexibility during this season as we didn't get to have this conference in person as we normally do, but we hope that this definitely helped you guys to be able to take care of your diabetes patients at school. Thanks again for attending.